He's a very, very fine clinician, eminent rheumatologist, written many publications, some books, one of which is here. Copies are available. Very apt topic, how to get out of the hospital alive. First thing to do is get in there alive, I guess. I'd like to introduce Dr. Sheldon Blau, whose clinical specialty is rheumatology. He's clinical professor of medicine at Stony Brook and in private practice of medicine in Massapequa. I've known Shelley for many, many years. He's extremely bright and well-versed in his field. He's going to talk to us about clinical approach to musculoskeletal problems in the practice of medicine. Shelley.
Thank you very much, Herb. Actually, Herb and I go back to the mid-60s. When I first came to this hospital, I was interviewed by somebody whose name was, what was his name? Marmelstein, right. And Dr. Marmelstein said to me then, because it was the mid-60s and rheumatology was not yet a specialty, Dr. Marmelstein says, why does the medical profession need a rheumatologist? I couldn't answer that question, and then as I was thinking about it driving here this morning, I'm not so sure I could answer it now. Rheumatologists have become chemotherapists, as we will see shortly. The vast array of new medications that have hit the market, certainly from the time I trained to now, has just reversed itself. Medications that we use regularly are no longer used. I thought that I was sort of uniquely qualified to actually speak about the history of many of these drugs because I was there for it, so to speak. The history is really what influences all of us, all of our personal histories with drugs, all of our personal histories with adverse reactions, and all of our clinical judgments. By the way, everybody here is in family practice, right? Everybody's internal medicine. We have no surgeons, no podiatrists, no, okay. That's good. That's good because you all are, the point of my lecture is for each of you to take something away from you that you can easily relate to your practice. So that if you change something that you do, then I will have achieved my purposes. Now, first I would like to speak to when I was in medical school, they told me when you give a lecture, tell them what you're going to tell them, and tell them what you told them. Now, this slide is simply to show you that I made this lecture up special for you guys. This isn't a canned lecture. This is all brand new. Now, this is what I'm going to tell you. And the first thing I'm going to do is tell you about the history of NSAIDs. And the history of NSAIDs is terribly important. When I was a rheumatology fellow at Albert Einstein, the only NSAID available was a medication called butazolone, as some of you know. Shortly thereafter, another medication was introduced for arthritis. It was called indomethacin. Indomethacin, the first patient to receive indomethacin of mine was my father-in-law. And it put him into renal failure and gave him the most severe headaches he ever had in his life. The only thing that saved his life is he refused to take another dose of it because of the headaches. Subsequently, he recovered from the renal failure, and I personally never used indomethacin for about another 20 years. Now, there were three very important studies that I put down, ibuprofen, huskisson, and placebo, that I want to discuss with you. And I think if you understand, oh, by the way, I have three handouts. The three handouts will cover some of the information we'll cover here. If I have time, I'll be happy to go over some of the material. The three handouts are, number one, the musculoskeletal manifestations of rheumatic diseases. Now, the musculoskeletal manifestations of malignant diseases. And the reason that I give you that is because as we see older patients, frequently malignancy is co-mixed with certain of the rheumatic diseases. We being Lou Tiger and Jim Sullivan and myself, we probably see a new diagnosed malignancy once a week when we evaluate elderly patients. Some of the malignancies, as you know, are intimately related to these diseases. That's what that article is about. I will not have time to go into all that I wish to tell you about osteoarthritis. So there's a very nice little review about osteoarthritis. And last of all, there's this book, How to Get Out of the Hospital Alive, which really has nothing to do with what I'm going to say today, but certainly influenced how I think about many of these things. I think anyone in the audience, as I look around, I think many of us are members of the Zipper Club, being those patients who have had bypass surgery, changed their orientation in discussing medical topics following life-threatening surgery. I know at least one of you has had this, and I believe that he's really changed. Let me tell you how the studies are going to influence what I did, and therefore what I'm going to tell you. Let me start with ibuprofen. In the mid-70s, the Boost Pharmaceutical Company came and asked 9 rheumatologists on the eastern coast whether or not we would study a brand new medication called ibuprofen. They also, because of FDA requirements, had 9 rheumatologists in the West Coast study ibuprofen. The dose was 35 milligrams 3 times a day. You will recall that the dose presently in Motrin is 200 milligrams. So that this was, if anything, the smallest dose of Motrin or ibuprofen that one could ever conceive. 9 of the rheumatologists on the East Coast said that the drug didn't work at all. I was one of them. 9 on the West Coast said it was a magnificent drug and really should be used immediately. The 9 on the West Coast thought the 9 on the East Coast lied and vice versa. I always thought that those guys in full-time medicine were lying about the efficacy of this. It was only years later, and this is really the point of this, that I understood that all of us were telling the truth. And that's what I want to talk about with a man whose name is Huskinson. Huskinson is an English rheumatologist. As an English rheumatologist, he has certain advantages, and he's able to do certain things that we can't do. For instance, he took 1,000 patients with arthritis and divided them up into 10 groups. Each group had 100 patients. And he gave then there were 10 NSAIDs available. He gave each group different NSAIDs and charted their results. When each group was compared, there was always a bell-shaped curve, with a small percentage doing very, very well, a small percentage at the other end doing very, very poorly, and most patients doing anywhere from a little bit better to a lot better. When by the way, he was able to do this because, first of all, all of the pills in England cost the same price, namely nothing, so there was no consideration as to cost. The second way he was able to do this was he really didn't need informed consent. When he took the groups and reestablished them into another 10 groups, everybody did the same. Everybody was on the bell-shaped curve. No matter what you took, you did exceedingly well if you were in the upper 10 or 15%, exceedingly poorly if you were in the lower 10 or 15%, and most of the patients were in the middle. When you mix the groups, the same patients don't do well on the other drug. In other words, what I'm saying is that although the bell-shaped curve is reproduced, the patients who do exceedingly well change each time. I never realized the significance of that study until I realized that the placebo response rate in osteoarthritis runs 30 to 40%. Now stop and think about what that means. I always used to think that a placebo response meant that the patient was a nut and that didn't have serious disease. Those of you who have seen the January 9th this year article in the New York Times, the magazine saying it was about a 10-page article by a lady on placebos will understand that the first bit of information and the second bit of information is easily explained on the fact that we all deal with any drug at all with placebo rates. The placebo rates, now let's just talk for a moment about what a placebo rate in a study such as, this is a complicated slide, but I want you to see just one thing. I want you to see the open circles here are placebos. This is in rheumatoid arthritis, a disease that has a lower placebo response than RA, but yet the placebo response still runs 30%. So what I'm saying to you is that most of the time, when a patient does well with what you are giving them, it's a placebo response. The response of any of the NSAIDs to exceed the placebo response has to be only 6% better. So that most drugs act by placebo response. The placebo response, I feel, and other people who have studied this, is actually pharmacologically induced and biochemically explained. In other words, these are not nuts. When things like endorphins and disease trackers of inflammation are plotted, these also improve so that you can't differentiate the placebo response from the actual response. Now, since ibuprofen got approved in relatively small doses by ultimately from Boots to Upjohn, a whole variety of NSAIDs came on the market, as you all know. Each of the NSAIDs was sometimes chemically different from the one before. As a matter of fact, a testimony to the fact that they were all Me Too kind of drugs is the drug NSAID. Are you all familiar with NSAID? NSAID is a non-steroidal anti-inflammatory that came out about 15 years ago that stands for ANSAID, another non-steroidal anti-inflammatory drug. All right? So that they all were, and by the way, many of you attended conferences and read articles about how one was more efficacious than the other, how one was more toxic than the other. The fact of the matter is, toxicity is related, number one, to half-life. The longer the half-life, the more toxic the drug is. The second thing is there are unique NSAIDs, and I'll show you some of them, that have unique properties that you should all be familiar with. The second thing is that the unique differences have to do primarily with some new NSAIDs on the market whose GI side effects are less than the previous ones, and we'll speak about that extensively. Now, I put in medical legal here because I realize that I am uniquely qualified to speak on this area, being your expert witness as a defense consultant for your malpractice companies. And the only thing, or most of the things that they speak to me about and that I comment on and sometimes get a report on, always in defense of the physician, is toxicity of NSAIDs and whether or not there was adequate monitoring. I'll simply mention one thing that happened just a few months ago. I was in court again on behalf of the defense, and a doctor who was being sued for a GI bleed that occurred with naproxen, in his defense said, when the plaintiff's attorney questioned him and said, "Why didn't you do an abdominal exam?" His defense was 3/4 of patients who have GI bleeds from NSAIDs have no symptoms of GI bleed, which is absolutely correct. The judge inappropriately interceded and said, "But doctor, what about the other 25%?" And that immediately stopped the trial and they had a second. The point of the story being, there are some legal aspects of, medical legal aspects of NSAID administration and their monitoring that I'll discuss in a few minutes. There also is regulatory effects for the use of narcotics. I'm going to show you soon how some narcotics are fine to use with the proviso, and by the way, no one is ever going to question you're using the appropriate dosage in a patient for as long as you wish. If you want to use Percocet, if you want to use Percodan, if you want to use Dilaudid, if you want to use any other analgesic, if you want to use 6 pills a day and you want to give the patient a prescription for a month, 180 pills, you can do that forever and no one will ever come to question. The only time that it will be questioned is if the dosage exceeds what either the manufacturer suggests or a reasonable amount. One doctor tried to write for 10,000 pills. If you want to write for large doses, you can't do it. There's also regulations. You can't just give patients a prescription for NSAIDs and say, "I'll see you again in a few years, and I'll show you why." Now, so those are the medical legal aspects of the new two kits on the market, as you know, are Celebrex and Vioxx, both of which have common properties. The common property is that they decrease the incidence of GI bleeding. I would like to, because this is in part a story of the history of NSAIDs, I would like to, if we get time, describe some newer concepts concerning the etiology of osteoarthritis, and then to quickly mention the new remitting-inducing agents that are present for rheumatoid arthritis, with major breakthroughs. But before I get those, I have to say a few words about steroids. And these, although it's going to sound like this is all very opinionated, most rheumatologists will bear me out on this. The first thing is that the most dramatic effect that a patient with rheumatoid arthritis can have will be with steroids. Always has been, always will be. That's the first point. As a matter of fact, 5 milligrams of prednisone or its equivalent is far more anti-inflammatory. The patient will feel far better with 5 milligrams of prednisone than he will with rheumatoid arthritis. The underlying feature is rheumatoid arthritis. Than any of these patients will with any of the NSAIDs. If I'm saying to you that, again, that NSAIDs have varying responses in osteoarthritis and in rheumatoid arthritis, but in rheumatoid arthritis uniformly, most rheumatologists, I think all rheumatologists would agree, that 5 milligrams of prednisone is far more efficacious than any of the NSAIDs, despite the fact that we want to use NSAIDs rather than steroids. We're all afraid to use steroids for regulatory reasons. All right, let's look a little bit. This was the placebo response. Let's look a little bit at, okay. Now, again about the placebo response. The placebo response, interestingly enough, is governed by these 3 factors. Cost. The more expensive a drug is, the greater the placebo effect. Now, I think you all know that. I think you know of patients I know of patients who 10 years ago flew to England to get the antifungal drug that I can buy for a few dollars, but it cost $8,000. You all know of patients who've been to the Caribbean for $10,000 IV treatments. The more expensive the drug costs, the greater the placebo response. And the availability, the more difficult it is to obtain the drug, the greater will be the placebo response. Now, certainly, you as caregivers, as physicians, what your attitude toward the patient and the administration of the drug is crucially important. Here I have provider's attitude. Now, there's a big difference between giving a patient a drug and saying, see if this works, versus, I've had really good experience with this, why don't you try this? The placebo response on the second, by the way, I think we should all strive for placebo responses. I think we should all see if we could establish placebo responses. The response to the second statement, I've had good results with this, will uniformly be better than see if this works. Okay, now, let's speak about NSAIDs in arthritis. This you can tell was a slide made by professional slide makers. First of all, NSAIDs are involved in half of all of these musculoskeletal disorders, no matter what's wrong, whether you have arthritis or connective tissue disease or a variety of other things. Half, interestingly enough, half of all of the prescriptions in elderly, I think that's all of us, really in this room, are for NSAIDs. And it's the most prescribed medication for osteoarthritis, representing a multi-billion with a dollar market. Anybody want to guess at what the reason for the pharmaceutical industry no longer promoting the drug is? When they came around and they said, Feldine was great. Come on, Boston, use Feldine, right? Boston always used Feldine. They stopped saying that. You know why they stopped it? Because when Feldine turned to peroxicam, then you couldn't get Feldine money for getting a peroxicam. In other words, a drug going off patent, and by the way, all of these will, I think there's 18 years on every drug, in the beginning they stop. When a drug goes off patent, that's the end of its promoting, and also the end of its sales. Nobody is promoting generic drugs to us. They're all promoting the high-cost versions, and perhaps appropriately so. High rate of early discontinuation, and perhaps if I were to isolate the nidus of this talk, is going to be about side effects. Now, this is a terribly important slide, and I don't want to go over it too quickly. I'd like you to look at it for a moment. There are anywhere between 16 and 20,000 people who die a year due to NSAID gastritis, bleeding. Now, that's an awful lot of people, 16,500. It's an awful lot of people who die, number one. And by the way, these 16,500, immediately know probably 100,000 lawyers. I think there's on the web there's killgrandpa.www. Immediately, attorneys will seek you up if you killed grandpa with NSAIDs, and immediately attorneys will look at what you did wrong if you killed grandpa. 16,500. I used to say in 1997 that this number was greater than AIDS. It was a very impressive statistic. In other words, more people died from GI toxicity from NSAID then in 1997 died from AIDS. Now, that means that this is the number. Now remember, most of these people who have died from GI bleeding, they may or may not have really needed a medication to function. And that's an important legal point, and I want to stress it. Because uniformly, NSAIDs have greater toxicity than analgesics. One should state, because it's asked all the time, how well was this patient functioning to necessitate the use of an NSAID? And I'll show you what I mean. First of all, again, most of that 16.5, probably 3/4 of it had to do with GI bleeding. All NSAIDs, including the ones that we're going to be discussing here, including the COX-2 inhibitors, are able to immediately cause superficial mucosal defects. I'm not a gastroenterologist, but if you look through the gastroscope, you see a lot of little punctate hemorrhages, and that's right away. Occurs in minutes, it's topical, and it's present in 1/3 of patients who use these. Usually, the symptoms of this immediate gastropathy are absolutely absent. One does not have any symptoms, although when you bleed, no matter whether it's a little bit or a lot, about 25% of patients do have symptoms. Now, what can you do? Well, here's the magnitude of the problem. Toxicity, over 100 million NSAID users this year. That's why we're getting bagels and coffee. It's prescribed, again, in half of all, certainly more than half of the visits that we see patients in. 14 million arthritis patients, which makes it bigger than Viagra. And it's endoscopically visible. This is such an important point. There are endoscopically visible GI damage. The longer you use it, the greater the likelihood you get damage. This is an argument, this 20 to 40% incidence, against using any NSAID, approved or not, in association with chemo. We never use NSAIDs with chemo. We never use NSAIDs because of this. I mean, if you're bleeding and you've got a whole lot of little punctate lesions, that's where you get into trouble. 50 to 60% of hospital admissions for GI bleeding are due to NSAID administration. Anybody want to guess what drug causes the greatest number of deaths per year? Deaths, dead. It's it. I'm sorry?
I would say Feldine.
No, it's aspirin.
Oh,
It's more. I mean, it probably would have been Feldine if everybody was still using it. I mean, you can't get Feldine.
Yeah,
Paroxetine. It's aspirin. There are more deaths from aspirin than there are from any other NSAID. Okay. Now, remember, this is for all of the NSAIDs. If you take them long enough, you're going to get dyspepsia or agita, as we call it in Massapequa. The frequency of gastric or small bowel perforation, 1 to 10%, this is any kind of GI disease, and less than 1%, although I'm not sure that number is actually adequate, will have certain CNS effects, liver effects, and certainly a rash is going to be higher than 1%. And renal insufficiency, and let me address that problem for a minute, because we have seen many patients who have gone into renal shutdown as a result of NSAIDs. The common denominators for renal insufficiency in almost all of these patients are hypovolemia, which means the combination of a diuretic and an NSAID often is a lethal. That's the one that makes you go into renal shutdown. So I personally, in patients who are taking, as you know now, there's a new theory as to the treatment of congestive heart failure, namely monstrous doses of Lasix. I personally do not use NSAID in anybody who's hypovolemic. Now, certainly the commonest way to become hypovolemic is diuretics, but you take an elderly patient on a summer day who's sitting outside and sweating a lot, that's the one who's going to have a kidneys low down. And then the other group, by the way, the group that half of the group of renal shutdown patients that we see with NSAIDs and diabetics, and again the same mechanism, they have poor renal perfusion. Now, is there anything you can do? By the way, again, remember, all of the NSAIDs are going to be as efficacious as the other, especially when you look at Hoskins' data. Is there anything that one can do to reduce the incidence of GI toxicity? Well, the first thing is non-acetylated salicylates. That would be something like disalcid. Remember, the less the toxicity also, the less the efficacy. So that disalcid or a non-acetylated salicylate will often work. It'll often work because of that bell-shaped curve. What if you give cytotec, or if you give protein inhibitors or H2 blockers? Will they decrease the incidence of gastritis and bleeding? The answer is yes, but if you know the only dose of cytotec that actually prevents the GI ulcers is 600 milligrams a day. 600 milligrams a day, and everybody was whopping diarrhea. Everybody, uniform. So that the people who made cytotec found out that they couldn't prescribe this dose, and what they do is they use 100 milligrams in some of their NSAID preparations. The 100 milligram dose with Voltaren does not prevent ulcers, so that's not going to happen. Certainly enteric-coated buffered aspirin is not going to work, and giving this stuff parenterally is not going to work. By the way, when Indocin came out with suppositories, which are very popular in England, they asked many rheumatologists to name them. Unfortunately, the name that I gave was innuendo, and they didn't want to use it. If I had my way, then and prodrug. So the only thing that is lowering the dose or giving a non-acetylated. So all of them do it, and you can't prevent it. Now, I put this slide in of osteoarthritis for three reasons. The first reason is, imagine that, by the way, whenever you order x-rays of the knees, you always order them standing. There's a very nice picture that I put in one of those articles about the difference in x-rays of the knees standing and lying down. Obviously, when you stand up, you obliterate the joint space. This is not true for the hip. Hips can be done lying down. X-rays of the knees have to be done standing up. When you stand up a patient, you notice that the medial compartment, by the way, don't look at this one because I'm going to get to this in a minute. The medial compartment is what's involved with osteoarthritis. Now, I'm going to slip in a little bit of the new concepts concerning why this happens. I would like you, the current concept as to why osteo always involves the medial compartments is explained as follows. Everybody put your feet on the floor and roll in, pronate. You know how to pronate? If you pronate, you roll in medially. No, don't roll your knees in, roll your feet in. If you roll your feet in, you'll feel the pressure in the medial side of the earth. The present theory is that osteoarthritis of the knees is a disease that begins in the feet because of excessive pronation. If that indeed is the case, then the podiatrists all along have been right. Using almost anything in your shoe will help to prevent this medial narrowing and this medial obliteration. I say almost anything because, as you know, some patients will come in with Dr. Scholl's pads that do nothing except make them taller. It has to be something that redistributes the weight from the medial to the lateral compartments. If you take a patient like this and simply put him into something that does that, either a commercially available for $40 orthotic, or send him to a podiatrist for $300 or $400, and he does the right job, then that patient in time will improve. This knee is not due to osteoarthritis. Actually, this knee is due to traumatic arthritis or rheumatoid arthritis, and involves primarily the lateral compartment. So remember, medial compartments, osteoarthritis. Now, just for a moment, since I mentioned some of the etiology of osteo of the knee, let me also mention what the etiology of osteo of the hips is. The Scandinavians have shown, by the way, the lesion in osteo of the hips. The lesion, although here's a hip that's stage 3, if we measure them radiographically from 1 to 4, 4 is almost total obliteration. The lesion always begins in the same place. It begins in the posterior inferior portion of the acetabulum. The Scandinavians have shown that most patients who have osteoarthritis of the hips have an abnormality in the angle of inclination between the femoral shaft and between the acetabulum. In other words, they're walking, if you will, with flexed hips. Obviously, except when it becomes terrible, you can't see them walk with flexed hips, but they're walking with flexed hips. And that indeed is the problem. When I was a rheumatology fellow, it was felt that there was very little as far as innovation in the synovial membrane. It's now been shown by studies of EM that the greatest innovation to your synovial membrane, the greatest innovation to the capsule of your joint, the greatest innovation to the soft tissue around any joint has to do with proprioception. And when you screw up proprioception, that's when you get osteoarthritis. That's when you get fairly rapidly advancing osteoarthritis or degenerative arthritis. Now, are there clinical examples? Sure. All the diabetics, all the neuropathies, Charcot's joint, they will all give premature osteoarthritis because of loss of position sense. So position sense, terribly important. All right, I went into that. Now, for a moment, if you have a hip, if you have hips like this, the best that anybody can do, short of replacing them, is to make you more comfortable when you perform a whole variety of physical activities like walking, going up and down stairs. No NSAID, no medication is going to make this patient feel obviously like you did 20 years before, or not so maybe 40 years before. So is it reasonable then for us to give pain medications? Take some Tylenol, see if it helps. Well, the ARA, American Rheumatism Association, my union, some 10 years ago issued a very remarkable statement. They said the first therapy for osteoarthritis of the hip or knee should be Tylenol, acetaminophen. And if the patient doesn't do well on acetaminophen, then you can think about other things. I mentioned that to you because we have many patients with hips and knees who look just like that, who we keep on prolonged analgesics. The prolonged analgesics, in our experience, do not lead to addiction. We're not afraid to give repeated prescriptions for Percodan, and we do it all the time. And Percodan, on a long-term basis, probably is safer than a whole lot of the other ones. So you know, pain relief, less GI renal, as a matter of fact, you don't get them. And the cons are, of course, everybody takes these stuff, it's constipated. Now, there's a homemade slide. Okay. Now, there are some NSAIDs that have kind of funny characteristics and funny side effects. Excuse me, I don't mean funny, I mean peculiar. The first thing is that Telectin, for those of you who teach it, Telectin has been reported as causing a pseudolymphoma syndrome. You have a patient who suddenly tells you that they had a biopsy that looks like a lymphoma, they've been taking Telectin, stop the Telectin, the lymphadenopathy goes away. Feldene produces, Feldene peroxicam produces, this is according to O'Brien from down south, it produces a sun sensitivity. He says that's irreversible. Once you get it, you can't go out in the sun forever. He scared me, Bill O'Brien. He scared me when he told us about it. And ever since, I take all my patients off Feldene before the sun. Next, Cliniris, that's Solomon, ibuprofen, Telectin, and as of about 2 years ago, I reported one case from Nassau County Medical Center. These all produce a transverse myelitis and an aseptic meningitis. Now, if you don't think of it, you're never going to make the diagnosis. I'm happy to tell you that with one case of ibuprofen, I was called many years ago to Long Island Jewish Hospital. The information about Motrin had just come out. It was a little old lady who suddenly was in the hospital for rheumatoid arthritis and suddenly couldn't urinate. She was found to have a transverse myelitis. I was absolutely brilliant. I made the diagnosis the next day. It all went away. Just luck. But think of it. Think of aseptic meningitis, and think of there was a case many years ago in Massachusetts General that you probably don't remember now, but it was a case of Chet Elliott, of a young 17-year-old boy who came in with what looked like meningitis, and he had meningitis. He was jittery, he was tapped, and indeed he had aseptic, meaning non-bacterial meningitis, stopping the ibuprofen that he was taking made it go away within 24 hours. Now, Meclamin is probably one of the drugs that's capable of causing cholera-like syndrome. I mean, if you use Meclamin in the recommended doses, it produces diarrhea like we've never seen. And now the new one, Celebrex. Celebrex is one of the COX-2 inhibitors. It's a very fine drug. It's the only COX-2 inhibitor that's approved for rheumatoid arthritis. The other one, Vioxx, is not approved. What does that mean? Now, you can be sure that if Merck can get approval, they're going to get approval. And you can be sure that they have been doing, spending millions and millions, if not tens of millions of dollars trying to get approval. Why they haven't gotten approval yet is very interesting. I don't know the answer to that, but we will find out in time. Now, the only downside of Celebrex is if you have this, just spell it wrong, if you have sulfonamide sensitivity. Now, you gotta watch out here. I just had a patient who has lupus and who has sun sensitivity, and Celebrex controls some of her symptoms. She was down in Florida and developed a whopping rash, and then I found out that not only was she taking Celebrex, but she also had perhaps a history of sulfonamide sensitivity, but she was also taking a diuretic with sulfur. So if you're allergic to any of the sulfonamides, there's a whole list of them that the Celebrex people will give you, then you're also allergic to these. Indomethacin is probably one of the drugs that accelerates osteo of the hip, and it accelerates osteo of the hip because if you've seen anybody with a large dose of Indocin, usually stage 3, stage 4 osteo, the Indocin works really well, and they don't even know that sometimes they just do everything. In other words, it's like, I can't get out of the chair, I can't walk a block. On increasing doses of Indocin, if you don't kill them like my father-in-law, then they do well for a brief period of time, and it's felt that the reason that there's acceleration of the joint space narrowing is because they have done too much. Okay, now, these are NSAIDs I have known, and these are NSAIDs that have killed. The first one is, of course, butazolidine. Judging from everybody's gray hair, everybody knows of butazolidine. Butazolidine was a fine drug. I think it was originally used in horses. It produced regularly hypertension, which didn't bother very many people. It regularly produced ulcers, which didn't bother very many people. The thing it did, though, was it wiped out your bone marrow. And it wiped out your bone marrow if you took it and then stopped it and then took it and then stopped it. That was the way to do it. In other words, patients have been on, and patients of mine as well, have been on butazolidine for years without going off it. Usually patients with ankylosing spondylitis, they did well. If they then stopped it and started again, that's when you wipe out their marrow. It was subsequently taken off the market. Any of you remember Oraflex? Oraflex, sure. Oraflex sent my kids to college and to graduate school. Oraflex was an Eli Lilly preparation that was finally released. And when it was finally released, on the week it was released, it was found that the half-life was 2 or 3 weeks. And if you're an elderly patient and you took Oraflex, you died. You died of liver disease. So Oraflex was taken off the market. Just a small personal story is the man who was responsible for Oraflex for Eli Lilly as soon as it was removed from the market had a heart attack that was, I'm sure, related to that. It was taken off the market. And there was a drug, SU-4885, that was put out by Sandoz that regularly caused diarrhea. As a matter of fact, it regularly caused diarrhea to such an extent that finally they decided not to use it for arthritis, but to use it for constipation. Okay, now we have to, for a moment, speak about DMARDs. Oh, okay, good. I'm in good shape. Okay. Now, the DMARDs are disease-modifying drugs. These are drugs that are capable of reducing, not making the patient feel better, although hopefully they will, but these are drugs that will reduce the number of erosions that one sees in rheumatoid arthritis. Now, I want to tell you that that's a very hard thing to quantitate, number one. Number two, it also is supposed to decrease the amount of articular cartilage loss. That's easier to establish almost in retrospect. But these new drugs, these drugs that are anti-biologicals like Enbrel and Remicade, these drugs are absolutely superb. They're absolutely superb, but we do not know of their long-term toxicity. And there are many fine, world-recognized rheumatologists who will not use them for a few years until the toxicity is recognized. The ability of these drugs, of Arava, Enbrel, Remicade, and cyclosporin to remit the disease is why they're used. But remember, these drugs all have a mortality. Not only a morbidity, but a mortality. You can die from taking these drugs. So, remitting inducing, I don't think, when I first came here many years ago, I was far more political. I mean, following the open heart surgery, I became less political. I think when I was more political, I would say, sure, everybody can use these drugs. Now that I've recovered from open heart surgery, I can say, I think these drugs should be used only by rheumatologists. Either rheumatologists or hem-onc people. Because these things you have to monitor very carefully, toxicity. And toxicity, for instance, with cyclosporine, which is I don't have to tell you, it's used for renal transplantation and the cyclosporin continuum. Now, here is the final residue. Here's the nuts and bolts. Here is the nidus of what you should know about NSAIDs and Celebrex. If you look at placebos on Celebrex, if you look at placebos, you don't get significant GI toxicity. The other thing, you don't get GI toxicity. You compare the Celebrex and the NSAID toxicity, look what happens. Here, out of 535 years, you have an incidence of 1.68, roughly with Celebrex. Now I want you to remember, using Celebrex in a patient who has an ulcer is a mistake. You still can bleed, but the bleeding is reduced by 80%. Now I have to tell you something that very few people know. If you are taking prophylactic aspirin, if you're taking 10 milligrams a day, very small dose, you decrease the COX-2 effectiveness by 10%. If you're taking 50 milligrams, again a small dose, a baby aspirin is 87 milligrams. If you're taking 50 milligrams, you decrease the COX-2 efficacy by 50%. A full dose of aspirin may reduce it by 80%. That means that somebody who has an ulcer and who really needs an NSAID, you might want to use one of these. You might want to protect him with other ulcer protecting medicines, but if he's on prophylactic aspirin, you may not be doing much to decrease his incidence of GI toxicity. So in really very, very susceptible patients with a history of PUD, patients with a history of hiatal hernias, patients with blood before who really need these things, you have to evaluate whether or not the aspirin should be given this way. Okay, now, what other GI toxicity? I mentioned besides GI toxicity that one sees renal toxicity, particularly with low blood volumes. Hepatic, you know that many of these drugs cause hepatic abnormalities. The fact of the matter is, most of the patients who you find, you put them on an NSAID and you find that his SGLT goes up to 500, he probably has a history of underlying liver disease, whether it's fatty infiltration, whether he's a diabetic, whether he had hepatitis, whether he was an old boozer. And as a matter of fact, I don't use NSAIDs in patients who have a history of hepatic disease, because you can take a well-compensated liver and totally decompensate. I mean, you can throw somebody into hepatic failure, necessitating liver transfer if somebody has liver disease and you use NSAIDs. Skin, you all know. Anybody can get a rash. The CNS we've mentioned, and this is penias. The commonest side effect of NSAIDs is thrombocytopenia, but sometimes you see leukopenia as well. Now this is something brand new. NSAIDs themselves may sometimes cause hyperkalemia. If you then use an ACE inhibitor, this can sometimes cause hyperkalemia. So what happens is, for those of us who measure electrolytes very carefully, you find potassiums in just this combination of 6.8, 7.2, and you always think it was hemolyzed blood. It's not. The patient has true hyperkalemia. Therefore, we do not use potassium salts or potassium-sparing diuretics in patients with NSAIDs and ACE inhibitors, because what happens is if you use diazide or spironolactone and give potassium, as many people do, then you're going to kill this patient. You're going to take it, and this is going to be the patient who's going to die at home from malaria. So this is something to remember, especially with spironolactone or diazide. Okay. Now, here are the medical legal aspects. If you take this slide into heart and take it into your practices, you will thank someday if you get sued. If you don't get sued, you get still thank. First of all, you should put down, rather than patient has osteoarthritis, you should put down the patient's ability to function necessitating a treatment. In other words, I have a painful knee. If I was not a physician and I went to see a physician and he put me on naproxen and I bled, someone would ask, how bad was my painful knee? How unable was I to function? And as a matter of fact, I want to introduce those three words to you, because those three words are going to someday save your neck, okay? Your patient's ability to function. If you say in your notes, unable to function without whatever it is, not just celebrants, that's good. Okay? Unable to function, difficulty function, can't walk one block. On the other hand, what tends to happen, and what always happens, is that you put down, a patient has osteoarthritis, he takes something, he bleeds, he sues you, and then years later, someone will say to you, well, how bad was it? And you have no idea. So, inability to function is terribly important. As a matter of fact, probably the only indication for steroids in rheumatoid arthritis, okay, let me say that again, because it's very important. Probably the only indication for steroids in rheumatoid arthritis is inability to function. Patient who can't get out of bed, patient who can't walk down a flight of stairs, inability to function, steroid. Now, the second thing is, as I said to you before, since 75% of bleeds are without symptoms, 25% are with symptoms, a judge or your defense attorney is going to want to know that you laid your hands on it, that you examined this patient. 25% do have symptoms. If you see a patient who's slowly bleeding, a quarter of them are going to have epigastric tenderness and right up a quadrant tenderness. It's nice to know, it's nice to note, and if you put down, as has been asked of defendants, the doctor to examine the abdomen, right? So if you have an NSAID, a patient on an NSAID, the bottom line is he should have difficulty functioning, and you should feel his abdomen and put down. By the way, don't say that the fact that I didn't put it down means he's negative. That doesn't work. You have to put down liver, spleen, kidney, abdomen, negative. Okay, that will save your backside. Now, since you can get abnormal renal function tests, since you can get abnormal liver function tests, since you can make somebody bleed, you would want to have some sort of monitoring. Now, certainly checking a patient's CBC and SMA 19 before you started, 2 weeks into it, and 6 weeks are minimal. That's minimal. Now, if a patient is going to stay on it for long periods of time, you'll want to check the CBC to see if they're anemic, and you'll want to check renal function tests. So, these are the medical legal aspects of NSAIDs. Now, how are we fixing time? Just right. All right. I'm going to stop here, and I'll answer questions because, and anyone who wants to ask anything about any rheumatic disease or its management, I'll be happy to answer. So I'll stop here and poise for questions.
What are you
I
treating?
knew you were going to have the first question.
What are you treating acute gout with?
We used to, as a matter of fact, we love to see acute gout. You know why we love to see acute gout? Because acute gout is a disease that most people don't remember this. If you don't do anything to acute gout, it gets better in about a week. Hemosis to it. You do nothing. If you started, and we sort of enjoy seeing it, if you give them allopurinol, you could keep it going on forever. Okay? So what we treated, by the way, and we don't use hourly cultures. Forget about that jazz. Okay? We used to use, because I was young, I didn't know about malpractice and stuff like that, we used to use IV cultures. So what we use now is 50 milligrams of indomethacin. Now let's say a patient has an ulcer, and you can't give him indomethacin. What you can do is you can send them to the podiatrist who will do, this is really interesting, what you guys can do. You can do a posterior tibial block. It's easy, it really is. You do a posterior tibial block. Posterior tibial block, what it does is it always hits the sympathetics, and what happens is that you raise the temperature and the attack goes away. So you do a sympathetic block, goes away immediately. That's the only indication to, really difficult. Indomethacin works well, and naproxen works well. I'm sure that large doses of all the COX-2s will work in those. Yes, other questions? So.
Yeah, can you speak to your version about Coumadin and Celebrex?
Sure.
The drug reps said, oh yeah, go ahead and use it if it's low-dose Coumadin.
I know. Well, you see, I didn't bring you because I'm not a gastroenterologist, but if you look at the mucosa, you always see little punctate hemorrhages. Now, I showed you that you can reduce punctate hemorrhages down by 80%. The rationale for their saying that you can use Celebrex with Coumadin is that Celebrex does not displace Coumadin from protein binding. In other words, if you use aspirin or if you use buzolidine, it displaces it, and what happens is you get more Coumadin, more bang for the buck. Here, they're right in saying that it doesn't displace it, so that your, if you will, proton or INR will remain the same. But the fact of the matter is, you're still producing in significant numbers of patients those small punctate hemorrhages. So we never use, although they say you can, we don't. We don't use Coumadin with unleaved. Perfect.
For a patient with 3 artificial valves, young woman, 50, OA that really stops her from function.
Sure.
She's young, vibrant, beautiful woman. Had a severe bleed on naproxen. Severe. She went up to see her cardiologist, who was Steve Delauder up at St. Francis. They transfused her, stopped the naproxen, and she said, I can't function anymore. What do I do? Vioxx came out. I called Steve on the phone. I said, what do you think, Steve? He said, try it, follow her INR weekly. Follow her CBCs, see how she does. She's been on Vioxx now, basically for maybe 6 months.
And doing well.
And doing very well. INR is well controlled, hemoglobin is stable. Am I scared? Yeah, I'm scared.
Well, and you should be. Also, you see, Vioxx has got a little funny business that Celebrex doesn't. Vioxx sometimes displaces. Sometimes what happens is you get an INR, and it's like boom, like this. The Vioxx sometimes does alter protein binding. Listen, we have many such patients who absolutely need something, and they need something whether they have cardiac disease or other. Remember that in elderly people, that NSAIDs will raise your blood pressure regularly because of fluid retention. So if you take somebody who's like an incipient congestive heart failure, adding one of the NSAIDs will worsen the skin. In that case, you'll simply watch as carefully as possible.
Well, what I do with this lady is watch her weight very carefully, because she's always in a minimum degree of failure at this point.
Right.
If her weight stays stable and her breathing stays about what it is, okay?
Well, I thought you were concerned about it because of bleeding, because of GI bleeding. You were because of worsening of a congestive heart failure.
The 2 main factors. One is the bleeding, because she had the bleeding with the naproxen, and she has congestive heart failure.
Okay. As a matter of fact, I'm glad that you asked that question for another reason, because it reminded me to tell you all about this. If you have patients on NSAID, any NSAID at all, and then they face elective surgery, they will get into trouble with 10 times the incidence of patients not on NSAID. So the advice that we give to all of our patients is that if you're going to have elective surgery, stop it a week before. And by the way, that's true of all of them. And it's a very important point because it's already been contested in court, and it says so in the literature, and most experienced rheumatologists do that. They just stop NSAIDs a week before. The patients will complain like crazy, especially, yours who have, who can't get by with Vioxx in your case or some other NSAID. They will complain like crazy, but you have no choice. Just keep them on Tylenol. And by the way, and the complications they get when they have the surgery, all kinds of hypotension, infection, arrhythmias. So I'm glad that you're moving.
Could you briefly comment on this Synavist?
Oh yeah, Synavist and high algae. Yeah, I'll comment on that. Sure, I'm glad you asked me about that, and I'll tell you why. Because I'll comment about that, and also I'll comment on chondroitin sulfate. Right? Remember the placebo stuff. That's it.
Okay.
You go and you inject at least 5 times. All right. Now don't forget, it hurts to inject it. I mean, even when Blue Tiger does it, it still hurts. And by the way, if God forbid you don't have insurance, even if you do have insurance, because you tell the patient immediately, this is $500 a shot.
That's not bad.
Yeah. Well, it feels a little bit better. And now after 5 shots, so I think that stuff is nonsense. I mean, I really do. Now. I'm happy to tell you, I always thought that glucosamine and chondroitin sulfate were also nonsense. And also, by the way, consistent with my theory of placebo price. I mean, that stuff is expensive. Now, I'm happy to tell you that glucosamine causes an elevation in cholesterol. So, all right, so now it has at least some toxic properties. I think if glucosamine were $2 a bottle, it would never sell at $40 a bottle. So that's my feeling about those drugs. Okay, if there are no other questions, let's enjoy the